Today, we're talking about metabolic bone disorders. These conditions all affect bone strength, but they do so in different ways. Our focus will be on osteoporosis, osteomalacia, and Paget disease. By the end, you'll understand the causes, risk factors, nursing care, and treatment strategies for each. Osteoporosis. Let's start with osteoporosis, the most common bone disease worldwide. More than 10 million Americans live with it, and millions more have osteopenia, which is low bone density that can progress to osteoporosis. The hallmark consequence of osteoporosis is fractures, especially of the hip, vertebrae, and wrist. By age 50, 1 in 3 women and 1 in 5 men will experience a fracture related to osteoporosis. Pathophysiology. Osteoporosis is all about bone resorption, outpacing bone formation. Osteoclasts break down bone faster than osteoblasts build it up. Bones become porous, brittle, and prone to fracture under stress that wouldn't normally break bone. With aging, several hormonal changes worsen this imbalance. Calcitonin decreases, so bone resorption isn't inhibited. Estrogen decreases, so bone breakdown accelerates. Parathyroid hormone increases, which stimulates even more resorption. This explains why women after menopause and older men as testosterone declines are at higher risk. Risk factors. Some risks are non-modifiable: age, family history, being female, small body frame, and certain ethnicities. Others are modifiable: smoking, alcohol intake, low calcium and vitamin D, sedentary lifestyle, malabsorption, and long-term corticosteroid use. Specific medications like anticonvulsants, thyroid hormone replacement, SSRIs, and PPIs can also increase risk. For men, low testosterone is a factor. Assessment and diagnosis. Osteoporosis is often called the silent disease because it isn't detected until a fracture occurs. Diagnosis relies on DEXA scanning, which measures bone mineral density. Results are reported as T-scores. A T-score at or below 2.5 confirms osteoporosis. The FRAX tool is used to estimate fracture risk over 10 years. In men, the Moore score may be more accurate. Lab tests help rule out other causes of bone loss, like hyperparathyroidism or multiple myeloma. Prevention starts early in life: adequate calcium and vitamin D, weight-bearing exercise, and avoiding tobacco and excess alcohol. Adults need about 1,000 to 1,200 milligrams of calcium daily and 400 to 1,000 IU of vitamin D. Weight-bearing and resistance exercise help build and maintain bone density. Postmenopausal women and older men should be screened and counseled. Pharmacologic therapy for osteoporosis. Medication decisions are guided by risk. Calcium and vitamin D supplements are often prescribed if diet alone isn't enough. Calcium should be split into smaller doses for best absorption and taken with meals or vitamin C. Side effects include constipation and bloating. Vitamin D alone isn't effective for preventing fractures, but calcium plus vitamin D together reduces fracture risk. Bisphosphonates. These are first-line drugs for many patients. They work by inhibiting osteoclast activity. Examples: alendronate, risdronate, ibandronate, and zoledronic acid. Nursing considerations. Take on an empty stomach with a full glass of water. Stay upright for at least 30 minutes afterward to reduce esophageal irritation. Don't take calcium or vitamin D supplements at the same time. They interfere with absorption. Watch for GI irritation, esophagitis, and rare but serious effects like osteonecrosis of the jaw or atypical femur fractures. Contraindicated in patients with low calcium, pregnancy, or severe kidney disease. SERMs, raloxifene. These act like estrogen on bone, protecting bone density, but without stimulating the uterus or breasts. They're especially useful in postmenopausal women at risk for breast cancer. Side effects include hot flashes and leg cramps, and there's a risk of venous thromboembolism. Rankle inhibitors, denosumab. This is a monoclonal antibody given subcutaneously every 6 months. It reduces bone turnover and increases bone density. Key risks include hypocalcemia, cellulitis, and osteonecrosis of the jaw. If therapy is stopped, bone loss happens quickly, so another drug must follow. PTH analogs, teriparatide. This synthetic parathyroid hormone stimulates new bone growth. It's used for patients at very high risk of fracture. It requires refrigeration and daily subcutaneous injections, limited to 2 years of use. Nursing process for osteoporosis. Assessment. Ask about diet, exercise, family history, fractures, medications, and lifestyle habits like smoking or alcohol. Physical findings may include kyphosis, loss of height, or pain from fractures. Nursing diagnoses: acute pain related to fracture, risk for injury related to fragile bones, lack of knowledge about disease and treatment, risk for constipation from immobility or medications. Interventions: education, calcium, vitamin D, exercise, fall prevention, medication adherence, pain relief, supportive mattress, heat, positioning without a trunk orthosis if needed, bowel care, high fiber diet, fluids, stool softeners, fall prevention, safe home environment, grab bars, lighting, no scatter rugs. Osteomalacia. Osteomalacia is a different metabolic bone disease. Instead of porous bones, here the bones are poorly mineralized. This makes them soft and weak, leading to pain, tenderness, bowing of the legs, and fractures. Pathophysiology. The root problem is vitamin D deficiency. Without vitamin D, calcium isn't absorbed well from the GI tract, so mineralization fails. Causes include GI malabsorption, celiac disease, biliary obstruction, pancreatitis, bowel resection, liver or kidney disease, can't activate vitamin D, renal tubular acidosis or phosphate loss, certain drugs, anticonvulsants like phenytoin, phenobarbital, poor diet, lack of sunlight, or poverty. Diagnosis: X-rays show bone demineralization. Labs show low calcium, low phosphorus, and elevated ALP. Bone biopsy confirms increased osteoid, or prebone. Management: treat the underlying cause. Vitamin D supplementation, sometimes calcitriol in renal disease. Supplemental calcium. Sunlight exposure. Orthopedic braces or surgery if deformities persist. Older adults are especially at risk if diet is poor and sunlight exposure is limited. Prevention through diet and safe sunlight is key. Paget disease. Paget disease, or osteitis deformans, is another unique disorder. It's a problem of localized rapid bone turnover. Osteoclasts resorb bone excessively, then osteoblasts thus overreact, forming disorganized, weak, vascular bone. Clinical features. Many patients are asymptomatic. Skeletal deformities, bowing of legs, enlarged skull, spine deformity. Patients may notice their hats no longer fit due to skull enlargement. Hearing loss from cranial nerve compression is common. Pain is mild to moderate, deep, and aching, often mistaken for old age. Warmth over affected bones due to increased vascularity. Severe cases may even cause high-output cardiac failure from vascular overload. Diagnosis: elevated ALP and urinary hydroxyproline, normal calcium levels. X-rays show mosaic bone pattern and thickened cortices, bone scans to assess extent. Management: NSAIDs for pain, walking aids, shoe lifts, PT for gait and posture, weight control to reduce stress on weakened joints, hearing aids if hearing loss occurs, surgical interventions for fractures or arthritis if needed. Pharmacology: bisphosphonates, cornerstone therapy, reduce turnover and relieve pain. Plicamycin, reserved for severe resistant cases. It's effective but highly toxic, requiring close monitoring of liver, kidney, and bone marrow function. Nursing considerations: teach about fall prevention and safe home environments. Support coping with deformities and chronic pain. Assess communication needs if hearing loss is present. Conclusion: metabolic bone disorders share a common thread: fragile, fracture-prone bones, but the underlying problems are different. Porous bone in osteoporosis, soft unmineralized bone in osteomalacia, and chaotic overgrown bone in Paget disease. For nurses, the essentials are early identification, patient education, medication safety, fall prevention, and support for quality of life. Our role is critical in keeping these patients safe, functional, and independent.